right, I have a couple of minutes, so I'm excited. I made it on time. All right. Let me turn off the sound. Change the thumbnail. I'll put the pretty thumbnail on there because I did it right before. And I still got a couple of minutes before we get started. But I'm excited because we're going to be talking about E&M. Hopefully this will help you guys to understand E&M a little bit better. Because I know E&M can be a challenge, but it's a challenge that is worth tackling. All right. Okay. Oh wow, we got a we got a lot of people. Yes, it's Happy July Fool's Day. I like that guy. The new guidelines, right? Of course, 2021. Of course, that is what we're going over. We're going to be covering a lot today. Not gonna lie, so get ready. And it's gonna be fun. Don't worry, it'll be fun. All right. So, welcome everybody. Thank you all for joining me. So we have Pallavi, Karen, Aurora, Guy. Thank you all for being here. All right, and Shannon, welcome. So we got a couple more minutes. So I did my first Christmas in July episode. I'm going to be filming for tomorrow's episode after the show tonight. I'm very excited. So I hope you guys enjoy the little stories that I have, coming out about, I just drank water. I hope you enjoy the stories that I'm going to be sharing throughout Christmas in July. About my experiences as a medical coder, and not just talking about, I'm not talking about coding tips on Christmas in July. It's more about just like sharing my experiences. So I hope you guys enjoy that. It's a little bit of a change, and those will be premiering at noon for the next 25 days while we have Christmas in July. So happy, what is it? July Fool's Day. At least that's what Guy calls it, and I like that, so I'm gonna steal it. Hi Jessica, hi Edel, hi Brenda, hi Ainsel, I think I said your name right. I hope I didn't flub that up. But anyway, I hope you all are ready. I'm studying for the, I have no idea what that is, CHONC exam. It seems like it's heavy on E&M, which I don't do on a regular basis. Looking forward to this. What is CHONC? What is that, Karen? Hello. Okay, good. I'm so glad. All right. Okay, good. 14 likes. If you are just tuning in, I hope you'll subscribe to my channel because I will be doing more of these, obviously. This is not going to be the only night I'm going to be talking about E&M. So, because there's so much to go over, and I just hope that the way that I explain it is helpful for you, because I know that it can be quite a challenge. If you have questions, please speak up, because I'm not a mind reader, and I don't know if you don't understand. And if you're leaving here not really understanding, again, speak up, because it's the only way you're going to be able to learn. All right. I did do the poll. Hi Trucy. Hi Jerry. Hi Blue. I'm driving, waiting on the train, but I'll be listening. Okay, great. Hi, Hannah. She's here for the E&M. Good. Okay. Wow, I've never heard of the certified oncology hematology coder, but and I know it has to be tough because it's neoplasm coding. So that's always a tough one, but a very good field to get into. I don't normally recommend the specialty credentials, but when it comes to like being like a tumor registrar and things like that, and taking that certification, oh yeah, I do recommend that. Oh, and that's through AAPC. Okay, no wonder why I hadn't heard about it. That's what I do. Do I need my book out? Well, I mean, you will, but I'm going to be talking about the basics because going over some of the polls that I did, the one poll that I did do on the community tab was well responded to. There was a lot of votes there. Thank you guys so much for participating in that. And I had asked the question, what do you struggle with E&M? And I'm going to read you guys the results before we get into the show. All right. So there were 43 votes, and this was done at the last minute, and it closed very quickly too. So that's why. But it's okay. So I had asked the question, I struggle with E&M because 21% said history of present illness confuses me. 12% said ROS and physical exam are not my favorite. And 60%, the overwhelming 60% said medical decision making is a nightmare. And then 7% were supposed to tell me in the comments. I only got one comment, and that was from somebody who said E&M coding is my Achilles heel. I think because there are so many elements involved that I get lost in the shuffle. I've decided to split it into smaller parts and review each part. I'm a new coder, recently got my CCPCS, so I must master E&M coding. I'm happy you're doing this video, and I am so happy to be doing this with you guys. Again, I'm gonna go ahead and start the show. If you are brand new to my channel, welcome. I am Blue, I'm a medical coder. And if you haven't already subscribed, please do. Like this, share this if it helps you at the end. All right, so let us get into it. If you have questions throughout the show, I'm going to keep repeating this because sometimes people have to be encouraged to ask questions. If you have questions, put it in the comments so that way I can get back to it later, or I can read your question and we can review it as we go along. But there were significant changes to evaluation and management January 1. So the reason that they are doing this now is in the outpatient setting, and this affects some of the outpatient setting, not all of it, okay? So like the ER, you're still gonna have to hit those, the elements for the history, the physical exam, and the medical decision making. So, but we are not talking about E&M tonight, I mean not E&M, but ER. We are not talking about ER tonight because that is a complete different animal when it comes to their E&M, and that has to be done on a separate episode. I want to keep this as clean as I possibly can because it's a lot and it can get confusing very fast. So we are only going to be discussing the E&M levels 99202 to 99215. Okay, so that's all outpatient visits. Okay, so that when you're going to like the clinic, that is when you're going to have these sets of evaluation and management codes to work from. Now, if you don't know, evaluation and management is basically the doctor getting paid for their cognitive work. They have to be able to manage, they have to be able to think and plan the care for this particular patient. Now, they get paid for their physical work, which is like the surgeries and procedures they do with like the CPT codes or, we're talking about other things, I'm not talking about inpatient right now, but for the outpatient setting, they're getting paid with their CPT codes, right? On the procedures that they do. For their thought process and for all the planning that they have to do and considering all the other conditions that the patient has, we have E&M. When you're learning E&M, it's important to review all of like your history, the review of systems, the physical exam, and the assessment and plan. It's important to look at all of that. But in the outpatient setting now, they've changed it where the the level can be reached either by medical decision making, like how complex is this or how not complex is this, or based on time. And if a provider wants to get a level based on time, this means that perhaps they spend a lot of time with this patient, and this time is all in the same day. This is not, well, I saw the patient on this day, and then I'm gonna finish my dictation tomorrow, so I'm gonna take all that time that I am dictating, and I'll just include that. No, it's everything that that provider did for that patient on that day. And it doesn't have to be face to face. It's not like before where it was 50% of the time was spent face to face, right? Or greater than 50% of the time was spent face to face. It's not like that anymore. So if a provider is seeing a patient and they happen to be a brand new patient and they have some radiology that they're going to review before the patient gets there, and they spend a half an hour reviewing this radiology and going over some previous documentation that the patient had sent over. And so that time is included in the time that, you know, they have for their visit on that day. So what this means is when a provider sees a patient for their visit and they're going over this visit and they're doing their thing with the patient starts to ask lots of questions. Perhaps they are nervous about their condition, or they have just general, like, how do I do this, or how am I supposed to set this up at my house, and that kind of thing. And they're having to do an extended amount of like talking with them. All of that time gets added on to this level. So at the end of the day, if that provider still has to be dictating their note, and like, I spent another 30 minutes, they call it pajama time because it's, you know, usually away from the office and they're at home. They called it pajama time. It's not a term that I came up with, although I thought it was cute. That time can be added as long as it's in the same day. So the total time that they have spent for this patient, caring for them, calling other doctors for consults, or you know, reaching out to other people to get referrals or whatever, that all of that is included, and a provider can get a level based on that amount of time. So if they have that plus extended amount of time, as long as they're being very clear in their documentation, I did this for this patient on this day, all of this time consisted of, and they sort of detail it out. It doesn't have to be a novel, but it does have to support their extended amount of time. Because now the whole thought process is, if we can get these providers away from, you know, doing these unnecessary bullets, we can get better care for our patients, so that they can concentrate on taking care of the patient and not how many check boxes do they need to hit. So that's why they did it that way. It makes it a lot easier because now, okay, you have to either pick from medical decision making or the time. If the time is greater, obviously, then that provider is going to get coding based on the level based on the time. If the medical decision making outweighs the time, right? Say, for instance, it's a brand new patient. They come in and they say, well, I spent 30 minutes for this patient on this day, and they detail everything that they did in this 30 minutes. But in this 30 minutes, in this visit, they happen to plan a surgery for this patient, and this patient has other conditions that are affecting their care. They're affecting, you know, the decision to do surgery, right? If they have diabetes, they got to check this blood sugar to make sure they're okay. If they have other conditions like, you know, any kind of blood clots and stuff like that, that puts them at increased risk. I mean, any kind of condition like that is going to put them at increased risk. GERD can put them at increased risk. Obstructive sleep apnea can put them at increased risk because that's an anesthesiology risk, right? When they put them under. Even being obese, morbidly obese, is also an anesthesiology risk because they can't put patients that are morbidly obese. They have to be they can, but they have to be very careful when they're putting them to sleep for surgeries. So that is increased risk. So if you're looking at a brand new patient, like say 99203, which is a 30-minute, it says 30 minutes on the time. If you're looking at the book, it says when using the codes, this code selection, 30 to 44 minutes of total time is spent on typically on this encounter, right? So if a provider says, I spent 30 minutes with the patient, and then they outline all of their plans and everything for this patient, they decide to do surgery, that's not 99203 because it's more intensive. So the way that it works is they're going to get level based on medical decision making. They decided to do a surgery, which bumps them up to either a 99204 or a 99205 because the medical decision making would be moderate or it would be higher depending on how they documented it. Now, of course, I did skip over this part. It's very important to understand the table of risk. When you are looking at your medical decision making, right? You have to come up with, it has to be appropriate physical exam. It's got to be appropriate history. So they don't have to do all this other stuff, but they do have to do a problem focused exam. They do need to make sure that they document that they looked at the area that needs to be treated. And they have to put that in their physical exam. And they have to do a problem focused history. What is a problem? What are they coming in with? So that way the documentation can support the level. When they go and they're thinking about doing surgery or something, or they're gonna go ahead and plan on doing surgery, when you look at the table of risk box, and if you don't have an E&M level tool, they do have one on the Novitas website. It's Novitas, Novitas, and they have all kinds of E&M tools there that are free. There's also emuniversity.com, which is also very good. They do have a free side and they do have a paid side. So just so you guys know, that it's another good resource. I will be leaving these resources in the description box when I do update after the show. There's plenty of resources out there, guys, so make sure that you look out for those. But your table of risk box, which is where you need to kind of focus and learn, because I think a lot of times when people are getting confused on how is this going to go? How do I know how high to push this? Is this low? Is this high? So when we look at the table of risk box, in your low box, right, under the number and complexity of problems addressed, in the low box you have two or more self-limited or minor problems, or one stable chronic illness, well-controlled hypertension, or non-insulin dependent diabetes, cataracts, BPH. That's an example of a stable chronic illness, if of course it's documented that way. And then you have one acute uncomplicated illness or injury like cystitis or allergic rhinitis or a simple sprain. That falls in under that first box of low, okay? Another example of low would be in the amount and or complexity of data. I know I skipped over the straightforward, but I'm going to get back to that at the end because I think it's pretty well easy to understand, but I want to kind of get into the low part first, and then low, moderate, and then high, and then we'll go back to that. And when you're looking at the amount and or complexity of the data to be reviewed or analyzed, it's limited, right? So category 1 must meet the requirements of at least one out of the two in order for this to match up. So, you want 2 of these to at least match up. Well, no, you need 1 in the box. So, talking to myself, guys. So category 1 is tests and documents, any combination of 2 of the following. So review of prior external notes from each unique source, or review of the results of each unique test, or ordering of each unique test. So this means for every test that they're ordering, it's considered unique. But if it is a panel, that is considered one test. So just so you guys know, because there's a panel that's ordered, but it is considered only one test. So just make sure you guys know that. And then category 2, it says assessment requiring an independent historian for the categories of independent interpretation of results and discussion of management or test interpretation, C, moderate or high. So it's very easy to hit this if the provider is documenting appropriately what they're doing, what they're ordering, what they're reviewing. All right. Because if you're paying attention to each one of these levels, you'll be able to know what you can hit and what you can't hit. And if there's something that is always missing with a provider, then this means that they need to be educated. So when you are needing to educate these providers, make sure that you're getting that done, because they don't know. They don't know this until we speak up and say something to them. And you can't be afraid of them either, because you're helping them. And if they may say to you, well, I've always done it this way, these E&M levels changed. So things have to change. And if a provider doesn't want to change, then that's something that you need to work on, and may possibly get your supervisor involved if they are just resisting. Okay. But then the other column is risk of complications and or morbidity or mortality of patient management. So low risk of morbidity for additional diagnostic testing or treatment. So when a patient has like a simple sprain and they're saying they're going to do over-the-counter drug management like Tylenol or Advil or something like that, that's over-the-counter drug management. That's not anything they have to get a prescription for. So that is considered low medical decision-making. Also considered low medical decision-making is minor surgery with no identified risk factors. Minor surgery being like minor procedures and things like that. So that is something like a shot, for pain or something like that. Minor procedures. So that's when like they have no other comorbidities, they have nothing else to consider. Like whenever you're going to give a patient like a pain shot, right? Like a Kenalog shot, which is a steroid, to help with like joint pain. You have to make sure that if the patient is a diabetic, that they're checking on their blood sugar, because that's, important when you're injecting a steroid. You don't want to do that for a diabetic patient whose blood sugar is already high. So that is something that you're going to move out of that box. But if it's really serious and it's documented, you want to make sure that you pay attention to that. But just something simple, straightforward, like if they had a sprain, they gave them a shot for pain and they got them good to go, then that would be considered low. Also, IV fluids without additives is also considered low medical decision making. So something you want to pay attention to if you are working in the ER. In the moderate category, so these are all considered moderate when it comes to the table of risk. So the number and complexity of problems addressed would be 1, chronic illness with mild exacerbation, progression, or side effects of treatment, or 2 or more stable chronic illnesses, or undiagnosed problem with unsure prognosis, like a lump in the breast, or acute illness with systemic symptoms like pyelonephritis, pneumonitis, or colitis, or an acute complicated injury like a head injury with a brief loss of consciousness. That would be in the moderate category for like problems. So if they have like the amount of data and reviewed and analysts of the data that they're ordering, you have category 1. It has to meet 1 out of the 3. So any one of these 3, if you hit this, you can hit this moderate category. And it says any combination of the 3 of the following: review of prior external notes from each unique source. So if they're doing that, they're getting records from someplace else, make sure that they're documenting that, because they are, it is part of the elements for their cognitive work. So something to point out to them. Review of prior external notes from each unique source. Review of the results of each unique test. Ordering of each unique test. Remember, panel counts as 1. Assessment requiring an independent historian. Category 2, again, you only need 1, right? Independent interpretation of tests. Independent interpretation of tests performed by another physician or qualified healthcare professional, not separately reported. So not on the same thing, but not separately reported. Okay, so pay attention to that one. Category 3 is discussion of management or test interpretation. Discussion of management or test interpretation with external physician or qualified healthcare professional / appropriate source, not separately reported. So if they have to call in like a consult, like, hey, what would you do? That would be considered an element in the amount of data reviewed and complexity of data and things like that. So that would count as one if that's what they did. And then it goes to the risk of complications and or morbidity or mortality of patient management. So when they have to do prescription drug management, and now prescription drug management is not going to count every single time. Like if they have like strep throat and they get some kind of antibiotic or some other medication, that's not considered well, it is considered prescription drug management, but it's not going to put them in the moderate category, because that's considered something that is going to run a normal course, and they're not going to die if they don't have this. So that's something to be aware of. They're talking about like prescription drug management, like if it's a diabetic and they have to, give them insulin, of course, that's going to be prescription drug management. If they have blood clots, and they have to give them like anticoagulants, that is something that is prescription drug management. If they have to give them like heavy duty pain relievers, that's prescription drug management. So those things are more complex. That would be considered moderate. If they're giving them like diflucan for like an infection, like a yeast infection, then no, that's not considered that. That's more straightforward. That is not straightforward, but it's low because it's regular, right? It's going to run a particular course and that's it. It's not something that is so complex. So even though these things on here are meant to guide you, it's not so set in stone, so that you have to really pay attention and know these things. This is why I tell you guys, pathophysiology is so important. And understanding your pharmacology is also very important, because it's part of really knowing. I used to think that when they prescribed any kind of medication, if it was a prescription they had to go to the pharmacy for, absolutely it was going to be moderate. I was wrong. Okay, you come in, a patient with a strep throat, obviously, no. If that's all they have, that's low, because that's going to run a particular course. So, and some of you may have heard that, some of you may not have heard that yet, but it is one thing that you will learn. So not always when you see a prescription, immediately think that. Look at what they're treating. Okay, again, like if they're treating athlete's foot or something like that, or a yeast infection, those are going to run a particular course and that's it. Going on, it says decision regarding minor surgery with identified patient or procedure risk factors. So again, like if they're doing minor stuff, right? And the patient is a diabetic and they have to consider this bumps it up to a moderate, because they have to really think about this now. It's not just something that they can do willy-nilly. Not that they do any of this stuff willy-nilly, but it is what they're doing. And knowing and understanding these boxes, how these doctors have to think about this stuff is the difference between a level 3 and a level 4, or a level 4 and a level 5. And it's your responsibility as a coder. And at the end of the day, the revenue that can be either lost or gained really depends on you. Yes, the doctor has a hand in it too with their documentation, but you interpreting that can make all the difference in the world. So again, it's your responsibility to know this stuff, guys. The other option is decision regarding major surgery without identified risk factors or procedure risk factors. So if a patient comes in and they have a fracture, right? And they're going to set them in, they're going to go ahead and do a closed treatment with a cast. That's a 90-day global procedure, so that's considered major surgery. This patient is otherwise healthy, so that is going to fall into the moderate category, because that's a problem, right? That's a acute injury, but is requiring surgery, so that's why it would fall into that moderate category box. Something to think about. And then diagnosis or treatment significantly limited by social determinants of health. And then the other one is closed treatment of a fracture or dislocation without manipulation. So when they have manipulation, where they got to put them like in traction, or they say it was like reduced, that's going to change your thought process now, because that's more involvement, it's more work. You know, when you when a provider is doing a closed treatment and they're just setting the patient, and not doing anything else, that's a lot different than some provider that has to go in there and manipulate the bone to get it into the right place so that they can put this cast on there and get it into the correct anatomical position before they finish up the procedure. So that's going to take more work. Again, these providers are getting paid for their cognitive work, and the procedure is their physical work. Okay. In the high box, so these are the more critical patients. So when you are thinking of medical decision making and the table of risk, if you have a patient who has one chronic illness with severe exacerbation, progression, or side effects of treatment, that's going to be in the high box, right? Or, acute or chronic illness / injuries that pose a threat to life or bodily function. Examples is multiple trauma, acute MI, myocardial infarction, PE, pulmonary embolism, severe respiratory distress, severe RA, rheumatoid arthritis, because when they're taking these medications for rheumatoid arthritis, it's all over their body. It's systemic. And these medications, if you ever look at the medications for rheumatoid arthritis, it's no joke. These have lasting effects on the whole body. It's not just one thing, it's the whole body. So it's very serious. Psychiatric illness or with potential threat to self or others, that's also considered a high risk in the table of risk box. So somebody that is threatening to kill themselves and be suicidal and things like that, that's considered high because it's threat to life. Okay. Peritonitis and acute renal failure is also up there because, again, you need your kidneys to live. You need all these other things to live. So that's considered high. The amount and or complexity of data, extensive. So it must meet 2 out of the 3. If you are wanting to get it based on this and something else, to support that high level of risk, any combination of 3 of the following: review of prior external notes from each unique source, review of results of each unique test, ordering of each unique test, assessment requiring an independent historian. So it needs at least 3 of those, right? Or category 2, which is independent interpretation of tests, independent interpretation of tests performed by another physician or qualified healthcare professional not separately reported. Discussion of management or test interpretation, with external physician or other qualified healthcare professional, appropriate source not separately reported. So you need 2 out of those 3 categories. And then for the risk of complications and or morbidity, you have the high risk, right? High risk of morbidity for additional diagnostic tests or treatment. Drug therapy requiring intensive monitoring for toxicity. So there are some medications that patients have to go on that they have to be tested regularly, and not just tested to see if they're at therapeutic levels. This is medications that are going to cause a level of toxicity if they have too much in their system. So there are some medications that they have to do regular tests on. So if that's a medication that they have to do regular tests on to monitor for toxicity, because you don't want to give them too much, that falls into that high risk box when you're looking at this table of risk. The other one is decision regarding elective major surgery with identified patient or procedure risk factors. So a patient who is morbidly obese, has obstructive sleep apnea, and perhaps has blood clots and needs an emergency surgery, that's in the high risk box because this patient very well could pass away because it's such a high risk. And when you get into a high risk like this, an elective surgery means that if they don't have this surgery, they won't die, but of course they'll be uncomfortable. But it's elective, meaning it can wait. If it is not elective, then obviously it's going to be, you know, high risk anyway, because it's something that they have to do to save the patient's life. So, but when they're talking about this, they're talking about that. Decision regarding emergency major surgery, like I just said, that falls into this high category risk. And then you have decision regarding hospitalization. So if they have to decide to, you know, either you stay in the hospital or we're going to go ahead and send you home, like to die, that is considered high risk. Decision not to resuscitate or de-escalate care because of poor prognosis. So if a patient does not have a very good chance to live, and they are going to, because sometimes doctors don't know what the outcome is going to be, right? And if they don't know what the outcome is going to be, but this patient is at this point where they're not, they have a do not resuscitate order, it's very important when you see this DNR in a patient's record that you select that code if that's what they are. There's a code for that. And a lot of times people will miss this code. It's very important to understand your Z codes, your status codes, because seeing something like that, okay, we know that they're in high risk because, you know, it's high risk of life. That if, you know, they may be alive for one day and then the next day they may pass away. But it's more intensive to take care of somebody that's like that versus a healthy person. So again, it's a higher thought process and a higher risk. So that's why it would fall into the high risk category. And then getting to the very simplest of all, the straightforward medical decision making. You have one self-limited or minor problem, like a bug bite. Patient comes in with a bug bite. Okay, simple, straightforward. They may put a little bit of something to stop the itching, but that's considered simple, straightforward. There's no amount of data that's being reviewed or anything like that. It's basically a very straightforward visit. Okay, it's a bug bite. And then the risk of complications, like any kind of surgery or anything like that, none. Minimal risk of morbidity from additional diagnostic testing or treatment. So it is very easy to see some things that are straightforward. And I'm going to look back here and tell you guys about some of the examples, the vignettes, hope I said that word right, that they have in the CPT manual. The AMA edition has the E&M examples in the back, okay, in Appendix C. This is why I always tell you guys, get familiar with your with your appendixes, because they are helpful and they do have a lot of really good information in them. Having quality tools, having really good medical coding books goes a long way. And I use the AMA Professional Edition for my E&M book. And I mean, there's other books, but you can't test with any of those other books, just so you know. When it comes to your tests for medical coding, you have to have the AMA Professional Edition for the CPT manual. Okay, you cannot test with anything else when it comes to CPT, because there's other ones, but they're not like this one. So, and all the associations require the CPT manual by the AMA. All right, let me take a break from reading this, and I'm going to check out these comments. Okay. Letitia says, hi, this is Tish. Happy to be here. Happy you're here. Hi, Simone. And Mitney says, hi, Blue. Hi. Hi, Christina. Hi, Jamie. Hi, Rebecca. Hi, Blue. I am taking medical coding class. When I'm finished, what is going to be the best kind of medical coding to do when you are new to the field? Anything. Don't try to go for anything that's easy. You go anywhere that they can put you, because basically you're looking to get in anywhere. Edo says, wow, the prescription part hit me. I always thought of a doctor prescribing prescription that it was moderate. Thanks, Blue. And see, that was something that I wanted to make sure that I brought up, because I was so excited today like the whole day thinking about, okay, I'm going to talk about E&M tonight. But I'm trying to think to myself, okay, what are some of the big points that I need to make sure that I point out? And that was one of those ones, because that was what I learned too. You know, it's just like, okay, anytime I see a prescription, bam, you know, it's immediately moderate. But no, if you have a patient with a yeast infection, that's not going to be moderate. You know, that's going to be low. Again, a patient with athlete's foot is going to be low. And so that's something to think about, you know. Hi, ASMR. Thank you guys for joining me. I really appreciate it. Ooh, this is nice. I got 38. So, I did leave the AMA updates for the E&M, which I printed it out, but it is in the community tab. I did leave the link so that way you guys can print it out for yourselves too, because there was a lot of updates that were effective January 1. And this is a very nice summary. It's going over all of it. It's going to be very comprehensive, so that way you guys can read it. When it comes to evaluation and management, it is going to take a lot of practice. It's not something that you're going to get right away. When I was learning this, we had to learn all the bullet points and all of the elements and everything else. So I literally had to read the book cover to cover. That's what I did when I was learning E&M, when I was in school, because everybody was saying that this was a course that a lot of people were failing, and people were failing it multiple times and couldn't get it because they didn't have somebody to explain it to them. So for me, I wasn't just doing what was assigned. I literally took the book, read it from start to finish. And that book was thick, you know, but I read it start to finish. And because of that, I've been able to understand it. So I always try to explain it the best way that I can, especially when I see people get stuck. But when you are looking at E&M, think about the fact that you're making sure that the doctor is getting paid for their cognitive work, what they're thinking and their thought process. And to be able to understand that is very valuable, because you don't want to be undercoding, because some people think, oh, if I undercode, you know, if it's wrong, it's okay because the insurance company didn't pay out as much. Undercoding is just as bad as overcoding. There is no, oh, this one is better to do, or I'll just go for the lower level. No, if you did something in a higher medical decision-making thought process, then yes, you're going to get the higher level. And if you're too scared, oh, well, it's a 5 and we don't ever report 5s, or we don't want to report 5s. If the doctor is doing something and he meets the level of a 5, then absolutely he should get a level 5, because anybody who audits that record will be able to see. And especially if it's documented appropriately, then absolutely. Because again, if they audit it and see, well, this was actually a level 5, again, it's an error. And it's a costly error because you can get a fine for that. You know, some insurances are really bad, you know, when it comes to those types of things. So code it appropriately, whatever you do. And if everybody's reporting, oh, it's a 2 and a 3. 2 and a 3, really? And they had to do some like sort of complicated thought process, or they had to plan for surgery and you're trying to give them a 3. No, that's not when you would do something like that, right? If they're doing like a pre-op on a pre-planned surgery and they're doing it the day before, that would be included. They would not get an evaluation in management. It doesn't matter how much time they spent with a patient. If that pre-op is the day before their surgery, the day before surgery and the day of surgery and 90 days thereafter is all included in the global package. I know I'm jumping from a little bit here, but work with me. The day before, the day of surgery, and 90 days thereafter, so it's a total of 92 days, is all included in the global package. If the provider has already planned to have a surgery for this patient, right? A week ago, he decided to do this surgery. And he says, I'm going to bring him back for a pre-op the day before. He is not going to get an evaluation in management at all for that patient because it's done the day before the surgery. That's included in the global package. If the provider had not decided to do surgery, and if they were coming in and he decides to do surgery within that 24 hours, and he says, okay, well, we're just going to wait for his food to digest, and then we'll do surgery on him. Okay, cool. Then yes, you can get an E&M for that, because that's decision for surgery. That's going back to that that table of risk box. Is this moderate or is it high, depending on the complexity of that patient, right? But if you have this patient who didn't have this pre-planned surgery and they decide to do it that day, that's when you'd have that medical decision making. That's when you'd be able to get an E&M for that. But if it's already pre-planned and they're coming in for that pre-op, then no, you're not getting anything for that. If that pre-op is done like a week before and they're saying, okay, well, you're just here for a pre-op, we're basically here making sure everything's okay, and then you're going to have your surgery by the end of the week, and it's just basically a checkup, then you're looking at a low level of 2, right? A 99212, because it's just basically a visit. You can't consider that the patient's going to go in for surgery, because that's already been accounted for in an E&M level prior, right? This is just basically a checkup. So even though they're there for a pre-op, for a surgery, doesn't mean that you're going to count that decision for surgery again. It doesn't mean that, oh, okay, that kind of thing. No. But that's in that case, if the provider is having to go over a lot of things and perhaps the patient is starting to panic because they're going to have their surgery in a few days and the doctor has to talk to them or kind of review like safety things with them, and how to set up their bed area or whatever, so that they don't hurt themselves. That would be something that they can talk about, and that would be something that they could put in their statement. Okay, well, I spent this amount of time with this patient, however 30 minutes, and it was reviewing all of these things and going over some of their radiology and things like that. That would be considered a level 4, because that would be 30 minutes. And when you look in the book, if you're looking at your 2021 CPT manual, it has where like 99202, which is a new patient E&M, there is no more 99201, but a 99202, it says for evaluation and management of a new patient, which requires a medically appropriate history. So basically just the basics of what are they coming in for, and or examination, and straightforward medical decision making. So that would be like a 99202. And again, I'm going to go over some of those examples in the back. Let me see what the comments we have here. Taylor says, I start my new job as a medical biller on Tuesday. Oh, congratulations. Jill says, so one possible condition, say hypertension, can bump up a code. This has been really helpful. I'm so glad. Yes, those major conditions, and the provider doesn't have to be treating those chronic conditions. That's something else that I should probably address. The provider doesn't have to be treating the chronic conditions, but it does need to say that the patient is stable, or what medications are they on, and that kind of thing. So that way they know that it was assessed and addressed, basically. But again, the provider doesn't have to be the one that's taking care of this condition. I hear this a lot from my ortho docs. Well, I'm not the primary care doctor. Okay, I understand you're not the primary care doctor. I got that. And I'm not saying that you are. What I am saying is that hypertension, that diabetes, those other chronic conditions like COPD, that is going to affect your care of this patient. Is this patient a smoker? That also affects, right? Because a patient who smokes is going to heal a lot slower, because vascularly it's compromising to the body when you smoke, right? Because it does damage to the body. But when you are when you're otherwise healthy, you can heal a lot faster. So again, making sure that the provider understands, is the hypertension stable? Yes, because they can list all of their prior conditions, but if they're not saying anything, okay, are you still on medication? Is this stable? Because a patient can go from having hypertension to not having hypertension. A patient can have diabetes at one time in their life. Perhaps maybe they're obese and they had diabetes, right? but then they had like the gastric bypass, they lost all this weight, now they don't have diabetes anymore, and they don't take any insulin or anything like that. Okay, well, they no longer have that condition. So even though they have this problem list of conditions like hypertension or diabetes, the provider needs to state that it's stable, or they're still on this medication for this condition. So that way you at least know, okay, this is a chronic condition that affects this patient's care. And if it does affect the patient's care, or they have to consider it, then they should be compelled to write that down, because that is what is going to support the level itself. Okay. Taylor, you're getting a lot of support. See, where do we go? Where is the community info? So when you type in medical coding with Bleu and my homepage pops up, there's all those tabs like videos, and then it'll say community, and in that community tab there's all of my announcements. So that's where the link is at. But when I update this video, after this video, after we get done with this live, I will leave the link for the AMA thing that I used to prepare myself for this. I will leave it in the description box, so that way you guys can read it too. And read it. Just read the whole thing, because even though you may not understand it, still reading it is going to help you, believe it or not. So here we go. See, I like that. I like seeing you guys congratulate each other and support each other. That's really, really awesome. But all of those chronic conditions affects their care. Yes. And that's what they need to know. So again, being very engaged with your providers goes a long way. Trucy says, so in the event that the patient comes in a week prior for like a kidney stone, and the doctor suggests surgery, however, nothing is planned, and the patient comes to the ER a week later and the surgery is done, is that a high level? So on that day, they didn't do anything else. They just, what did they do? Just stabilize them and send them home? Did they give them medication? Because, well, at the end of the day, they were thinking about doing surgery. They may not have done surgery. So again, what did they do? And that does affect their level there, you know. Jamie says, congratulations. But yeah, again, it's going to go back to how do they have it documented? And when they're saying, well, we could potentially do surgery on this, but the patient still needs to decide, or perhaps they'll say, well, let's just wait and see. That would be a good time to say, okay, how long did you spend speaking with this patient about this potential option? Is this something that they may or they may not have? Is it where it's going to be in the low, or is it going to go moderate? It really depends on their documentation. And so when you're looking at those types of things, it's the language of these notes that is going to go a long way to supporting whichever level. And yes, while we're looking at these, and this is giving us direction, right? Because again, going back to this prescription drug management, right? It falls into the moderate box, but it could also be low. This is giving us direction. So when you are looking at this note, is there other factors that are going into whether or not this patient is going to either have surgery or not have surgery, or are they stable right now? Because we can't level them based on what will happen in the future. We got to level them based on what they did in this moment. And how did they document in this moment? And so that's why that's really important. It's really important to know that. So when you're looking at, okay, what potential level am I going to give this patient? Is it going to be a low level of medical decision making, or is it going to be a moderate level of medical decision making? Which one supports? Because again, we're not coding for the future, we're coding for right now. Did they give them medication? Did they give them a prescription to help with the pain? That's in the moderate category. That's when you're looking at that level 4, all right? But if they said, okay, well, we're going to send you home, just, you know, we're going to give you some fluids for right now, and there's really nothing else we can do, and maybe if you come back We'll think about doing surgery if it gets really bad. You know, again, IV fluids is going to put you in that low box. So going back to how is it documented? And getting engaged with your providers to say, okay, well, what is happening? Well, it's only common sense. I hate when they say that to me. This is not common sense. I need to have it. You know, I can't just assume. I'm waiting for the comment to come through over here. It takes forever. They suggested surgery and the patient probably decided that they wanted to wait and see if the pain will continue or subside, but they come in a week later in the ER having the side pain. We need it in writing. Absolutely, Karen. Again, it was probably serious, right? But us saying probably is not going to support. So in that case, I would say, did they spend time counseling that patient? Did they spend time reviewing their radiology to see, okay, well, this is what is going to happen. So if they're doing that, if they're spending that time, then I would encourage them to be like, okay, make sure that you're taking track of your time, because, you know, the difference between a level 3 and a level 4, right? And a level 4, you would be looking at 45 minutes. 45 to 59 minutes is for a level 4 for a new patient. Excuse me. And so that would be acceptable because they can support their time based on, okay, well, the patient has a potential to have surgery, but the patient doesn't want surgery, and we're going to wait and see. This play this wait and see game. But I reviewed the radiology. I counseled the patient. This was for 45 minutes. And don't let them do this. It was greater than 45 minutes. It was greater than 60 minutes. It needs to be concrete. It cannot be it's greater than. Because I tell my providers all the time, if I see it is greater than 30 minutes, you're getting based on what you have documented. The medical decision making is based on what you have documented. It's not going to be based on your time. So the one side that is more beneficial, either the time or the medical decision making, is what I'm going to give them, right? Based on whichever one supports, whichever one is greater for that provider. Because again, they can spend 30 minutes and decide to do surgery, but that's like a level 4. That's not a level 3. And based on, if you went based on time, that would be a level 3. But they say don't get dependent upon time, about documenting the time. Don't get so dependent on it, because that is meant for instances when it's excessive, obviously, or when they've had to have extended amount of time. Then yes, in the same day. It cannot be the next day, even when they're documenting all their stuff. It cannot be time from that next day. It has to be in the same day. So that being said, again, if they didn't do anything for this patient and they basically sent them home, they did like IV fluids and sent them home, that's a 3. I mean, but again, I would need to see the documentation itself. But again, we can't code for what happens in the future. We got to code for what happens right now. If that provider had said, okay, you're going in for surgery next week, that would be a moderate, in the moderate category box, because that's deciding for surgery at a minimum, right? Based on their other conditions. If they had other conditions, then potentially it could go up to a high. But for straightforward, chit chat right now, then it would be a moderate, because that's decision for surgery, Let's see. And the doctor decides to do, okay, did I miss something? They suggested to do surgery, and the patient probably decided that they wanted to wait and see if the pain will continue or subside. But then they came back a week later to the ER having side pain, and the doctor decides then to do the surgery that day. Okay, well then that's something different, right? Jamie says, why did they leave the house? And that's what you are coding for. Yes. Sorry, that has nothing to do with what you're talking about right now. Why did they leave the house? That's funny. Coders aren't providers, and providers aren't coders. Haha. That's one of the reasons we need a good relationship with providers. Yes, and this is why I tell people, especially new coders. And I get the same thing every time. Blue, I'm scared. I was scared too. Trust me, I was scared. I was scared out of my mind the first time that I actually had to speak, like in a smaller group. And for some reason, I was okay in a bigger group. But I don't know if it was because the room was so small and I could like see everybody that I started to have a problem. I was like, oh my gosh, I'm so nervous, right? How can I do this? But the benefits of having a good relationship with your provider is supreme, because then you get to learn. You get to learn like what they're doing and how they're doing it. And the better you can get with them drilling down to the specifics of, okay, what is happening here, the easier it is going to be for you to hit these E&M levels, because it's going to be more transparent. You're going to be able to understand this more. It's not going to be this ambiguity of you trying to decide, okay, well, what did they do here? And why did they do this? And okay, well, what did they do? No, that's the reason that we have these E&M tools. That's the reason that we have this wonderful book, the CPT book. But looking at these descriptions, it's going to tell you right then and there how many minutes this particular level is going to go for. And of course, there's prolonged services, which is covered in this AMA supplement. It's covered in there. And it has not already been an hour. It has not already been an hour, guys. It's already been an hour. But one of the things that I did want to go over was some of these examples that they had in the back of this book. And sometimes people don't even know that these examples exist. But when you think about this manual, this CPT manual, all the answers are here. We don't have to add anything to it. It is all about getting familiar and getting confident and knowing what you're looking for when you're looking in this book. So it has examples in here, but for like since we didn't cover that. So these examples that they have here in the 2021 book are for like the inpatient stays. So like the pro fee coding, they do have examples in here for those. And then they have the consult examples, inpatient consults. Yeah, and there's basically what these would be in emergency department. I'm going to have to save these then for the next time, because I don't want to start talking about ER, because ER E&M coding is different, because that requires the elements. That requires all those bullets to be met. Where is it? Come on. All right. Yes, that's when we're going to start talking about like problem focus history, problem focus exam, and then straightforward medical decision making. So that's going to require the use of the E&M tool, and which I kind of wanted, like I said, I wanted to keep it on the office outpatient visits, so the 99202 to 99215, so that we wouldn't get confused. But it is very easy to hit these levels now. So it is based on medical decision making and based on time. And so really understanding that table of risk box is really going to help you. And like when I look at this table of risk box and I see like one chronic illness with mild exacerbation, progression, or side effects of treatment, I'm thinking like COPD with a mild exacerbation. That would be in the moderate category box, because COPD involves the lungs and it can get very serious. But it is a chronic illness. COPD is a chronic illness. So that would be something that would have like mild effects, progression or side effects of treatment. Or two stable chronic illnesses. They have two stable chronic illnesses. In the stable chronic illness, thinking hypertension, diabetes, those types of things, COPD, RA, those things are chronic, right? And if they're stable and they've got them on there, again, it's going to fall into that, and that's what they're treating them for, right? Well, not necessarily, but so that we can be illustrative, right? That would fall into the moderate category box, right? And when you're looking at a whole list of conditions on a patient, and it doesn't necessarily mean they're going to jump all the way to a high, right? That patient may come in with a lot of different things, but it could still be just a moderate, because especially if they're stable, if all of these chronic conditions are all stable and things like that, and the doctor's really not doing anything, or their thought process is a lot, but it's very stable, very controlled, that's when you're still looking at a moderate. It really depends, again, on the way that it's being documented. That history needs to be focused on what are they taking care of? What did they come in for? What did they leave the house for? as somebody, Trucy, I think it was Trucy who just said that. No, it was Jamie who said it. Why did they leave the house? Why did they go to the doctor? Because people don't like going to the doctor, or a lot of people don't like going to the doctor. But why are they there? What is affecting the provider's decision making for this? And sometimes people get into that hamster wheel of those E&M tools. You got to be real careful. It's got to be something that you're going to get used to if you need it in the beginning. And it's going to be, you never want to get into the fact that you can look at it and be like, oh yeah, well they did this, I'm going to give them a 2, or I'm going to give them a 3. No, it's not what you are going to give them. It is what the provider has documented. Look at their conditions that they're treating. How are they treating them? Is it just they're just coming in for refills and they're just moseying along the way? Those are the things that you need to make sure that you're being very clear about. Talking with your providers is a huge thing, guys. Hannah says that's the problem I have with the ER. Yeah. In the CPT book, that you're talking about the examples that are in the back. Trucy, is that what you're talking about? Was that a question to something I said? So do you guys have, what other questions do you guys have about E&M? Very much needed session. I'm so glad, Edel. I will definitely have to do one about the ER E&Ms. They'll have to be on a separate one because, like I said, I don't want to bring too much and be too overwhelming. What page do the examples start? It's in appendix, in the CPT professional edition by the AMA. It is in appendix C, like in cat, and it starts on page 893 in the 2021 CPT manual. Black belt. I'm over the moon. I have an assessment lined up tomorrow, and then recently was told I passed an assessment and the manager wants to send me for an interview next week. That's awesome. You see, that is so great. That is really great. Just keep it up. Keep it up. Is this going to be your first job, black belt? I can't keep water down. No, okay, well, that's still good anyway. That's still awesome. I'm so glad that you're gonna get this job, and even though you have another interview lined up, that's still good because they're really looking at you now. I want to move somewhere where I can gain more experience. Good for you. I like that because that says, okay, I don't want to just stay stagnant. And you're being proactive about it. You're doing something about it. You're willing to move, because sometimes, like, move to another job. Because sometimes people get like scared. They don't want to try. Once they get a job, they're like, okay, I'm fine. And they get scared. They don't want to move. But it's always good to move. And especially when you know that you have a potential to be able to grow someplace else. Very important. That is really great. Justin, black belt, that is inspiring. That's the kind of thing I hope happens to me next year. Well, you are definitely very resourceful, Justin, so I don't see that being a problem for you. There is a lot of work out there right now, and that is true. That is true. Crossing my fingers for you. Yes. We all are. Trucy, I found it. Didn't know they were there. Yes. Looking in those appendixes is everything. Because it has all that information back there. And you may think, okay, well, I just need the codes in the front. Yeah, I just need the codes in the front. No. It's the whole book. Like I said, the book has the answers. It has anatomy plates. It's got all this other information back there. I'm probably going to have to do a video where I'm just discussing just the appendixes in the CPT manual. I think that would be good to encourage people to look that up. But yes, what else can I say about E&M tonight? We talked about prescription drug management. We talked about decision for major surgery. And major surgery not meaning always that they have to go to the OR. You just have to make sure that you know what procedure codes are major surgeries procedure codes. And there is a website, I'm going to have to look for it, but you enter in the CPT code and it'll tell you how many global days are on that CPT code. So that would be a good resource, especially if you were brand new and you're just learning. P.S. My name is Jenny. Oh, Blue, you might remember me from like fall of last year. I videoed with you a resume and stuff. I love your laugh. Oh, thank you. Yes, I do remember you. Thank you for helping me. Oh, you're welcome. You're welcome. Oh, no, I do know who you are. I know exactly who you are. Ah, so you made the leap, did you? I'm so excited. Please let me know. Please let me know what happens, because sometimes like when I spend time with people, I always kind of wonder like what happens to them, But yes, I do remember you. I know who you are. I'm so glad. I'm very proud of you. That is awesome. You just keep it up. You just keep it up because you were very determined then, and I know you're going to be very determined now. So I'm excited. Yes, always challenge yourself, coders. Always challenge yourself. The power that we have as coders is to be able to challenge ourselves. The more you challenge yourself and not get complacent, the more valuable you're going to be, right? The more experience you get under your belt, the more valuable you're going to be, because that means you can go anywhere. I'm not afraid anymore. I used to be afraid like in the very beginning, right? But I'm not afraid anymore because it's like, okay, I know I can be put anywhere and thrive, because that's what I do. I mean, I'm a researcher. I know how to look stuff up, and I know that that's what I'm called to do. My love is ortho and podiatry, though. Don't take me out of there, because that's what I really like doing, and I like teaching it too. But when it comes to being able to be put anywhere, it's nice. It's nice to have that option. It's nice to be able to not only think that you're good at just this one specialty, but that you can go anywhere. I don't have that fear of like, okay, well, what happens, God forbid something happens tomorrow at my work. You know what I mean? Like we all get let go or whatever, like knock on wood. I could go anywhere. I can go anywhere and still be okay. It wouldn't have to be with just ortho. It wouldn't have to be with just podiatry. It could be anywhere, Getting strong in E&M takes a lot, guys. It takes commitment. And when I was first in medical coding, not at my first job, but the second job when I was a profi coding. Now that was a challenge. It was a challenge to learn E&M on the profi side, and think about that. You have to think inpatient but outpatient, but doing, and then when I went to doing regular clinic coding, that was like a challenge for me as well, because it's like, okay, how do I switch this off in my head? Because I was so used to, there needed to be so much documentation, and now there had to be only a part of that in order to meet levels. And so now it's even simpler. The people who are getting into medical coding now, you guys have it really good when it comes to like office outpatient and not having to think about all these elements and things like that. Because now it's just based on time or based on medical decision making. So as long as you know and understand how to hit those levels of low, moderate, or high or even straightforward, then you're good to go, you know. Of course I will, she says, adds more feathers to your cap. An assessment I just did, one I passed, had a whole section on E&M. I know, because you had it, and I told you back then you had it. So that's really awesome, especially because we just went through those updates. And I know when they are assessing new coders, not that you're new, but other new coders, looking at what your skills are for E&M is something that they're going to really pay attention to, especially if you're going to clinic coding, okay? Pure Faith says, hi, Blue. Speaking of podiatry, a healthy minor patient is diagnosed with a contusion of the left foot. An x-ray is done, but he was told to just purchase over the counter. I coded it as 99282. What do you think? What is that, a consult code? What is that? No, that's the ER. What's a contusion of the foot? I probably wouldn't have gone. I don't know. It's hard. It's hard for me to say because I can't see the documentation either. It's hard to say without seeing the documentation if it met expanded problem focus, expanded problem history, and then low medical decision making. Although I think it should be straightforward. Problem focus history, problem focus exam, straightforward medical decision making, because it's minimal, and he told him to get over the counter, but he did do over the counter, and it needs 3 out of 3 to hit, because in the ER, right, for evaluation and management of a patient, which requires 3 out of 3 key components. So did that provider document an expanded problem focus history, expanded problem focus exam, and then that low complexity? It bothers me because it's just a contusion, and I would think that would be straightforward, self-limited or minor. That's not even an acute, uncomplicated illness or injury. That's not a simple sprain. That wouldn't even go to a simple sprain. I don't know. To me, it sounds like it would be lower, but again, I'm not looking at the documentation. Good night, Brenda. Pallavi says, my CPC exam is next week. What kind of E&M code they ask? I never took the CPC exam, so I don't know. And they have an outline of the CPC exam on the AAPC website. It's like an injury, swelling of the foot, but it still only falls under contusion, which is a self-limited or minor problem. And it would, in order for it to be low, it would need to be like an acute, uncomplicated illness. The only thing that's even making it there is that over-the-counter drug management. But again, you know, we need 2 out of these 3 boxes to line up. So we need something. I don't know. Straightforward to me. I got it. Thanks so much. You're welcome. I hope that was helpful. Letitia, I will start a 7-month coding program in October. Happy I found you. I'm happy you found me too. So we can, let's see, waiting for it to come over here. So we can push the code up based on the risk, or lower the code based on the risk. Yes, because when you have, well, you need 3 out of the 3. The 3 out of 3 needs to line up when it comes to the ER. And I know I promised you guys I wouldn't do the ER right now, but I'm going to go ahead and do it anyway. Where did it go? Where did it go? Hold on 1 second. How did I get away from the ER already? Hold on. Here we go. The 3 out of the 3 needs to line up. So it needs to be expanded problem focus history, expanded problem focus exam, and then medical decision making of low complexity. If it was expanded problem focus history, expanded problem focus exam, and then straightforward medical decision making, it immediately drops it down to the 99281. Because remember, you can always go back, you can't go forward. And it has to line up. Those 3 boxes have to line up. So, Jenny, doesn't part of the MDM include mortality of risk or something? Quickly looking it up. Thank you. Good night. Good night. So it's got to match up 3 out of 3. And if there's one that's off, it can drag it down to the lower level. Because you have 99282 and 99283 both expanded problem focus, but you notice how 99283 is moderate complexity and then 99282 is low complexity, so they can still have expanded problem focus history, expanded problem focus exam, but it's that MDM, it's that medical decision making that is going to change everything. So in order for those bullets to meet, it's gotta go. It's just, to me, saying a contusion, a bruise is low is kind of hard, because there's one acute uncomplicated illness or injury. And then it says a simple sprain, and a contusion is far from a simple sprain. Let me get back here to these vignettes back here. Let's see what we can come up with. What does the book say? All right. So 282, that's what you want to give it, right? That was what we were, the question. Okay, so an example of 99282 according to the AMA CPT manual, right? One of the examples here is emergency department visit for a 20-year-old student who presents with a painful sunburn or with blister formation on the back, okay? Or a child presenting with impetigo on the face, like a rash, localized rash on the face. Another example is a patient with a minor traumatic injury of an extremity with localized pain, swelling, and bruising. Oh, well. Did they talk about pain, swelling, and bruising, or was it just the contusion? Because that does fall underneath that, the 282. I guess so. Another one is an otherwise healthy patient whose chief complaint is red, swollen, cystic lesion on his or her back. Another one is poison ivy. Another one is impetigo with tropical over-the-counter treatment. Topical, not tropical, topical. It's hot enough anyway to be tropical. And then the other one is a minor traumatic injury of the extremity with localized pain, swelling, and bruising. No imaging done. That would be like a pediatric patient. That would fall under 282. So I guess that would be right. It's just hard. You know, it's a bruise. And then for like an example of the straightforward low, I mean, not straightforward, but the straightforward medical decision making for the emergency would be like removal of sutures, or like a tetanus shot, or uncomplicated insect bites. So I guess it would be a 99282. I guess that would fall. It's just hard because I can't see the documentation. Letitia, are you going through for your program? Yes, 282. Yes, he talked about swelling. Okay. So that answers that one. We answered that one. Seems weird though, right? It seems like, should it be that high? But then again, you know, it depends. Depends on how it was documented. So as long as he did all that, you know, oh wow, yes, please, I'm looking forward to your ER lesson. It's confusing and it seems different. Thanks so much. Oh good, I'm so glad. Well, see, I learned something too, okay? Because like the book says contusion, that says the scenario was contusion, okay, you know. But are we hitting the elements? Of course, you know. Expanded problem focus history. expanded problem focused exam. And that would be like, I didn't know if I should go into like the elements, stuff like that. I was like, well, if I'm just going over medical decision making and time, then I'm good, because that can go over on another episode. So hopefully, hopefully that helps. All right. So, anything else on the E&M questions for the outpatient office visits, 99202 to 99215? Anybody? Still looking to see if there's anything I need to go over. But we know what a high would be, right? High in the table of risk box. I think it's pretty well straightforward. But really knowing those medications too kind of helps. And knowing those major surgeries really does help too. Alrighty. Okay, so it's quiet. I got crickets. So we're good. Because even on LinkedIn, what did they say on LinkedIn? What was the percentage? Not many people responded on LinkedIn. For some reason, when I do like polls on LinkedIn, it just I never get a lot of feedback on LinkedIn. But when I do, when I put it on the community tab, the YouTube community tab, I get like a lot of votes and stuff like that. And I know like a lot of people may want like, oh, we want to see like actual scenarios. It's not about seeing the scenarios, because you could still be confused looking at the scenarios. But it's about understanding. Do you understand the elements? Do you understand what you're looking for first, before you get into all that? Do we know what history points are? Do we know what physical exam points are? Do we know what review of system points are? Do we know all of these things? Do we understand this first? Do we understand the table of risk box? Do we know what this means? Do we know like about surgeries and about medications and things like that? Do we know? And I think at least, when we're explaining this, when it's explained and it's talked out, and as I've gotten feedback from a couple of people, it did help. So that's what I think anyway. I think it works better. But on LinkedIn, the 13 votes that I got, HPI confused 8% of the people. ROS and PE is not my favorite. It's for 15% of the people, but the MDM is a nightmare, 62%. So it's very similar to what I got on YouTube. And then I put other comment below. 15% voted that, but then didn't comment. Okay. Thank you, Blue. You're a lifesaver. Oh, thank you, Edel. Hannah. So outpatient E&M is just based on the straightforward, low, moderate, or high. The medical decision making, yes, or time, based on that. Justin, I don't even have LinkedIn. How important is it for your career? I think it's not that important, but it is a good place to network. Brandy on the rocks. Wow, thank you so much for your knowledge in coding. I never thought about medical coding as a career. I had my first interview 2 weeks ago. I looked on YouTube and found your video very helpful. Oh, I'm so glad. It is a good networking tool. That's what everybody agrees, yeah. My job is kind of dead end in a way, so I didn't think much of it. I should sign up, though, especially when I get closer to my certification. This has been really helpful. Oh, good. I'm so glad. KY. I'm in a medical coding program. It's so hard, LOL, but also cool to learn. It is cool to learn. That's what I say. I was telling everybody on Instagram, I said, be there or be square. LinkedIn is great for networking, says Hannah, and job finding. Think of like professional Facebook, but you don't have friends. You have people that you've worked with or coordinated with professionally. That's very good. That's a very good example of the way it should be on there. For the most part, it is. You get one or two creepers, but yeah. It's pretty much a good place to be. I think I have like 400 connections on there. I don't think many people check their LinkedIn. I rarely log into mine. Well, Trucy, it's funny because I didn't think LinkedIn was so important, and then I kept getting pushed to get a LinkedIn, get a LinkedIn, get a LinkedIn. Finally, I got a LinkedIn. And so I've been making connections, and that's, people find me on there on LinkedIn. That's how people find me. So, I guess it all depends. Recruiters will search keywords, find you, and contact you with opportunities on LinkedIn. Jenny says, I love that definition, professional Facebook. Yeah, it's funny. Blue, what is your ethnic background? You're so beautiful. Oh, thank you. I'm Hispanic, so my family is Spanish. And a lot of people think I'm Filipino. I get that, are you from the Philippines? I get that a lot, but no, I'm Hispanic. I think my undergrad is that what pushed us to get LinkedIn's. Letitia says, I'm being proactive by following you. Oh, that's awesome. Yes, I get asked that a lot. It's funny. I was working in Arkansas with phone books. Yes, it's off topic because I think our discussion about E&M is pretty much done for the night anyway. I was working in Arkansas one time, and and this older gentleman, he came right up to me and he goes, you speak very good English. And I go, thank you. I've been speaking English my whole life. He goes, I can't even hear your accent. What part of Mexico are you from? And I said, I'm actually not from Mexico. And I'm from Texas, right? And so I was telling him, I was trying to explain to him like where I'm from in Texas, And so he's like, and then he goes, so how old were you when you learned English? And I'm like, I've always spoken English. And then he goes, but you're Spanish. You got rid of that accent. I'm like, okay. And I'm being nice to him because he's an older gentleman. What are you gonna do, And so, and of course, we're all there, and everybody's looking at me like with these big saucer eyes because they're like, oh my God, what is she gonna say to him? And I was just very kind with him because I was like, okay, I was like, what, 19, 20 when this happened. And so I was just talking to him, and then I said, no, I'm from Texas, and I've always spoken English. And he's like, wow. And so as we're talking a little bit more, he was like, because the phone book office was out of a VFW hall. And and so he was like, well, let me bring you a soda. So I said, okay. So he brought like ice, and he brought like a nice cold Coke, and he poured it in front of me, and and did the whole setup and everything. And he was fascinated by me for some reason, But he was just like, he says like, I can't, I really thought that you only spoke Spanish when I saw you. And I was like, no. I said, I speak English. And so, but he was a really nice gentleman, he shook my hand and everything when he was done talking to me, so I guess he was happy that I didn't get upset. To me, if you're not around people that look like me, it could be, that you just don't know, you know what I mean? So, but he just felt comfortable enough to come up to me and ask me. But I thought that was sweet. I always think about that when people ask me where I'm from. Yes, you look Filipina. I get that a lot. Oh, and when I went to Michigan, they thought I was Italian. They were, because I went to the UP for vacation. And if you've never been to the Upper Peninsula of Michigan, it is one of the best places, one of the most peaceful places to go. And when I went there, it was in May. It was like the early summertime, and they still had chunks of ice in the lake. Like literally like whole chunks of floating ice in the lake. And I saw people out there like walking on these big, huge chunks of ice. I said, y'all crazy. I said, I will stay right here on this nice sand, and I will just sit here and dig my feet into the sand and enjoy this lake. But no, I will not be out there on no ice, big, huge ice chunks. And so I went to this one restaurant, and I sat down. And the people there were there, of course, they have these wonderful Michigan accents, which I love accents. When I hear people from like New York, New Jersey, Michigan, Minnesota, I love to hear them speak. So I was sitting there and I was having, I think I was having lunch or dinner, one of the two. And so they go, "You're not from here." And I said, "No, I'm visiting. I'm from Texas." And they go, "Are you Italian?" And I go, "No, no." I said, "I'm Hispanic." And then they go, "Oh, where's your family from?" And I said, "Spain. That's my grandfather. He came from Barcelona." And they go, "Oh, okay, okay." They go, "Well, we thought you were Italian." I said, "No, not Italian, although Italians are very beautiful people." I was like, "No, I'm not from there, you know." um, let's see. I saw a lot of comments coming in. Brandy, she's laughing. "I'm nervous about the vaccine. I'm hesitant to get it. I'm too at risk, so I got it when I could." Justin says, "Does medical billing and coding make good money?" Yes, they do. Justin, a lot of workplaces are requiring it though, and you're at a much higher risk of it as a medical coder, I think, because we work in hospitals and physician places. I am 20. Do you think if I stay in coding 10 plus years, I can make good money? Of course. Angel, at my school, at MTI, they have me doing 10 key. Is that important to learn for medical billing and coding? I love that you said 10 key. Because whenever I say 10 key, people get confused. 10 key is very helpful because, of course, you're using alphanumeric characters when you are entering in these codes. Yes, it is helpful. Brandy, yes, ma'am. I'm from Detroit. I can't live anywhere that cold. That's why I went in May to the UP, because I went to this place. Oh gosh, what was the name of it? The Upers place. It's like this tourist trap. They have the Upers tourist trap, and then they have this huge thing. It looks like a football goalpost that has how much snow that has been there, and this thing was like huge, tall. I'm like, no way could I be there when it is snowing like that. I will stay in my native of Texas. No. I can't live anywhere that cold. Greetings, sister. I just landed a great paying job after 2 years. Keep up the hope. Jenny, I have a terrible southern drawl, but I still love it. There's nothing terrible about a southern drawl. It is very charming and very nice. I love southern drawls. Yes, the Lord will open a opportunity for you. You gotta be persistent. Keep working hard. At 20, you could do anything. KY, goodness, you can actually be a doctor herself, not the coder who does the codes for the doctor. Exactly. I don't want to be a doctor, says KY. I plan on doing creative work on the side. I'm a military spouse. Thank your husband or your wife for their service. So coding is what works for me now. And then I work remotely. It's great opportunity to work remotely. Coding is good. So is anything, KY, you can think of. Yes, because you're at a very good age to do whatever it is that you want to do. Do you talk on the phone a lot for this job? Nope. Jenny, I wish I had kept up with my roomie from undergrad. She was a doctor, and I could have been her coder. We would be unstoppable. She was studying to be a doctor. Let me rephrase that. Well, I mean, that's the thing. You know, when you get into a facility or when you get into a hospital or something like that, it is not unheard of for a doctor to leave with their coder and take their coder with them. So if you have a really good relationship with your doctors, you know, if they end up going someplace else and maybe they go into private practice, it is not unheard of for that to happen, you know, because if a provider gets very used to their coder and their coder is very knowledgeable and they know that they have their back and, you know, they make a really good team, it is not unheard of. Okay, so it is actually more beneficial for them because they don't have to live with the mystery of, does this person know what they're doing? So, but yes. So anyway, I'm going to go ahead and close this one up because we have been on for an hour and a half. people. I hope this was helpful because, again, there's a lot to go over on E&M. E&M is not that scary, folks. You just have to keep working with it, whatever you do. And I hope I've explained the table of risk somewhat better because, you know, there was no other questions that came in. Oh, you're welcome, Karen. Did you ever name your truck? But just review the sections that you're working in. You know, if you're working in the outpatient setting, obviously 99202 to 99215. If you're working in the ER, review the ER sections, but get to learning those elements and those points and what they mean, so that way you can start to get sharper when it comes to spotting those things. Thank you, Blue. Have a good night. Thank you, Edel. Thank you, Pure Faith. Thank you so much, Blue. Very informative. Good. I love the remote opportunity of coding. It always allows people like me to be behind the scenes to flourish. Yes. Not yet, says Karen. Okay. This is great information. Thank you. Oh, thank you so much, Letitia. Yes, this was great. Thanks again. 10 a.m. here, and I'm watching. Oh, so are you in the Philippines? Because if it's 10 a.m., then you must be in the Philippines. God bless you. But thank you so much. Thank you, Shannon. Thank you, Jamie. I appreciate it. All right, guys. So I'm going to wrap this one up. Thank you guys so much for joining me. I hope you learned something. If this helped you, please share it. Please subscribe if you haven't already. And I will see y'all on the next episode. Bye.